an reticulocyte, right? It's probably our favorite labs to get in the Sickle Cell Center. And I want to make sure everybody understands why we're getting them and what we're looking for. All right, so we're going to talk about what do you get with a CBC? What does it include? We're going to briefly talk about different causes of elevated white counts and different types of anemia, and about a mean corpuscular volume, which measures the size of the red blood cell. So when you think of how we look at a lot of our labs, if you've ever done a coin counter, right, at the grocery where you put all your coins in and it sorts them and then determines all the money, that's kind of what happens when we measure cells in a counter, except that instead of using size and shape, it uses antibodies on the outside of the cells. And that's what you're looking at in that lower right corner. It's showing you how it measures different cells. And while it shows you based on size, what they're really measuring are the different antigens expressed on each white cell. And so obviously that's important. And then we also talk about hemoglobin, hematocrit, and platelet count. White blood cell counts are actually very age dependent, so they're going to be different in children than adults, and they have to be corrected for nucleated red blood cells. Most red blood cells that are in our bloodstream outside of the bone marrow have spit out their nucleus. When they still have the nucleus, it confuses the machine and it makes them think they are white blood cells. So if we have somebody who's very anemic and making a lot of red blood cells and they have nucleated red cells, that's because their bone marrow is saying, we need more red cells. So it's going to spit out those nucleated red cells that are sort of like babies. And the biggest issue is that they can be miscounted as white cells. We also see racial differences in white count. They've recently changed the name of what used to be called benign ethnic neutropenia. And now I can't remember the other name of it, but it goes without saying that some individuals, especially children, specifically in people who are of African descent, may have slightly lower white counts. And it's benign, and it's not something we need to worry about in adults, but in case you've heard about that. And we talk about all the different types of white counts of white blood cells: neutrophils, lymphocytes, monocytes, eosinophils. So this is when we think about white cells and we think about stem cells, like we think about from inside the bone marrow. That stem cell is, it can become anything in the blood. So when we think about a stem cell transplant and you hear people say, I don't want, that's eugenics or something along those lines. We can't make a new foot or something like that out of a stem cell. You can only make, out of a hematopoietic stem cell can only make blood cells. And these are all the different types of blood cells that they can make. And as you can see, a megakaryoblast becomes platelets, and erythroblasts are what eventually produces red blood cells. And then myelocytes and lymphocytes are their own different lineage. You also hear people talk about left shift. This is one of my favorite memes. If you're too young, you may never have seen The Princess Bride. Great movie. But a lot of people talk about a left shift, and what they think they're saying is someone has a lot of neutrophils. That's actually not what a left shift actually means. If you're left shifted, it means that their body's making a lot of immature cells. So that means they're making bands or those early blast cells in here. And we see some left shifts during people who are severely infected. But I see a lot of people misstate that, and they'll say, oh, they're left shifted because they have a lot of neutrophils, and that's not accurate. What does it actually mean to be left shifted? It actually is how we describe the maturation of a white blood cell. So this is the order of maturation. When you're a hemonc fellow, you get to learn how to differentiate all these cells, which is really fun. But what they really are, again, talking about, and this is why it's left, so it's that you're supposed to have these cells on the right, these segmented neutrophils that have these different lobes. But if you're having a lot of sepsis or infected, you're going to have bands, which are these cells with this U-shaped nucleus. And so you're shifted the wrong way, or shifted to the left. Your body's putting more immune cells that are immature into the bloodstream. So we think about an elevated white count. Of course, the most common reason is that it's infectious, or that's the most common concern that we have. Everybody always worries about infection. There are certain medications. The one that we know best and like least is steroids. So when we have systemic steroids, it can cause increased white blood cells. And it's because it causes the bone marrow to release more white blood cells. Seizures, after someone has a seizure, they're almost always going to have a higher white blood cell count. Other inflammatory conditions, including sickle cell disease. So many of our patients have a baseline white blood cell count that's much higher than normal. And so I'll often hear about our patients in other hospitals who are getting antibiotics, or they get admitted because their white blood cell count is 16. And if you actually pay attention, that's their normal white count. Of course, malignancy is another concern, or immune deficiencies and Down syndrome, but we're not going to worry about those today. But as I mentioned, especially in people with sickle cell anemia, their baseline white count is usually elevated. Now, in people in hydroxyurea, because hydroxyurea will decrease that, it's one of the ways hydroxyurea actually works. Because remember yesterday how we talked about that the more neutrophils you have, the stickier the inside of the blood becomes. So the more white blood cells, the more you have a potential for having a sickle cell crisis, which is why you'll often see patients who have the flu, or they have, for example, a UTI. So they have more white blood cells, so they're more likely to have a secondary crisis. Why do we get low white cells? Also because you can be infected and cause low white blood cells, also certain medications, also malignancies. Autoimmune diseases can cause low white cells, or bone marrow failure syndromes, which we didn't used to think much about in sickle cell, but we do worry a little bit more now that perhaps their bone marrow burns out as they get older and they actually develop malignancy. That's a whole nother discussion. Immune deficiencies. Neutrophilia is age dependent. That means a lot of extra neutrophils, and within that first year of life, they actually have more neutrophils, and then it becomes more normal really, really quickly. This is something that we talked a lot about yesterday, about how that neutrophil works and what it does. It rolls along the inside of the blood vessel, and then it eventually sticks. And once it sticks, it can get into the blood vessel, which is important when it wants to go fight some infection. But as we talked about, these little attachment thingies are called selectins. That's what crizanlizumab or Adakveo is blocking. It's blocking the ability of the neutrophil to stick to some of those, not all of them. And as a result of that, it makes it so the inside of the blood vessel is not such a sticky, narrow place. When we see increased neutrophils, it's usually a chronic infection or chronic inflammation. Sometimes you can see them if someone's been sick recently, they'll rebound with a lot of them. Those are the main reasons. We can also see during stress situations, our bodies release neutrophils, again, with steroids or hypoxic stress or specific acute infections. When you're neutropenic and your cells are low, it's often age dependent. And as I mentioned, this used to be called benign ethnic neutropenia. It has a new, less stigmatizing name now. I just don't remember the new name of it. But it does mean that you'll sometimes see kids, especially who get sent to a hematologist because they have low neutrophil counts, but they actually have enough neutrophils in their bone marrow, so they're not really immune deficient. It's just in their bloodstream. Their bone marrow hasn't released them yet. This is different causes of neutropenia, nothing that you need to worry about. In our case, the most common cause of neutropenia is too much hydroxyurea, which is why it is highlighted here. But importantly, there are other drugs that can also cause it, the most common being anti-seizure meds. So we may be able to give less hydroxyurea to somebody who's on a seizure med. What about eosinophils? They're really my favorite white blood cell. And yes, I'm a hematologist. I have favorite white cells. They're the cutest, which is sad but true. But they're this very pink color. And sometimes you can see really high eosinophils, and it should make you think of allergies or dermatitis. Those are really the most common. The textbook answer is always parasites. Thankfully, we don't see a lot of them. But if you see somebody's white count that has a whole lot of eosinophils, it's something that should at least raise an eyebrow and make you want to look a little further that something else is going on. And then basophils, we rarely see a lot of them. And mostly I just don't worry about them because they're so rare in what we do. Monocytosis. Monocytes are another way that we know your bone marrow is active. And for our purposes, it is most important when people have had an aplastic crisis. So an aplastic crisis means something has caused their bone marrow to stop producing cells. That's what aplastic means. And usually it'll restart. And the first white blood cell your body wants to make when that bone marrow restarts is a monocyte. So it's useful because it tells us the body's recovering. After our patients have a bone marrow transplant, that's also the first cell we see to start to recover. And it really tells us they're on the road to recovery. And then lymphocytosis, when you have very few neutrophils, but a lot of lymphocytes, Old school, we worry about pertussis and mono. Of course, we worry about leukemias and lymphomas, but usually it means you're more apt to have a viral infection than you are to have a bacterial infection. When do we see lymphocytopenia? Really, the two things that I think about in our population are we do always have to worry about HIV. We try to get annual HIV tests on our patients, partly in individuals who are just highly sexually promiscuous, but also, and very importantly, even though the risk of transfusion-mediated HIV is so low that we haven't seen one since 1984, we always want to be checking for that. In rare cases, you can get this funny thoracic duct leakage. We've had 2 patients have this. I have no idea why, but needless to say, if your lymphocytes are really low, they need to be explored. So our favorite cell, right, the red blood cell, is supposed to be squishy. You'll see if you look on a CBC, they'll read like all these different words. So it might say their target cells present or spherocytes present or whatever else. For the most part, in our case, what they're reading doesn't matter. And a lot of people will tell you, especially if they don't know sickle cell, oh no, the peripheral blood shows lots of sickled cells. To which I say, yes, that's because they have sickle cell disease. The state of their current being is not related to how many sickle cells you can count on a peripheral blood smear. And in fact, as you can imagine, when you take blood out of someone, you're taking the blood away from oxygen. So remember, the more hypoxic, the less oxygen there is, the more likely that cell's going to sickle anyway. So don't worry about that so much. Hypochromia is relevant. I call these lifesaver cells because when they get really hypochromic, they look like sucked out lifesavers. These are what an iron deficient patient looks like, and it's very, very clear when you see it. The rest of these you don't really need to worry about. It's just more that you see them written down, so I like to have the pictures. So the mean corpuscular volume is the average volume of a red blood cell. And we do use the MCV a lot, and that's because we hope that people taking hydroxyurea have increased MCV. It also can tell us if people more likely carry thalassemia, then their cells are going to be smaller, so that MCV is going to be around 60. In rare cases, there's other reasons the cells can be too big, folate deficiency, B12 deficiency, and they can have these really big cells. But the main reason we like the big cells is fetal hemoglobin. If people have a lot of fetal hemoglobin, the volume of the cell goes up, and it's a way to measure how effective your hydroxyurea is. Little bitty cells, again, most indicative of iron deficiency, but also seen in thalassemia or hemoglobin E disease. The slide here is a picture of iron deficiency. See how it looks like a bunch of people that sucked on lifesavers and spit them out. That's what iron deficiency looks like in the blood. Macrocytosis, this is big cells. We really like big cells. You can see them on the right. To me, they look like healthy and happy. And in our case, they usually are because they're filled with fetal hemoglobin. There are other reasons, as I mentioned, that can be abnormal that you have big cells, but we don't worry about those too often in our case. And then you get this other number called the MCHC, or the mean corpuscular hemoglobin concentration. It's how you can calculate it by dividing your hemoglobin by your hematocrit. And for the most part, I would just tell you to ignore it. You really don't need to worry about it in anything that we do. Anemia, the word anemia means you're not making enough red blood cells. It means you don't have enough red blood cells. And whenever someone doesn't have enough, it's either because they're not making them, they're destroying them, they're breaking apart, or they're losing them because they're bleeding. So we always want you to have a reticulocyte count. That's why we love our reticulocyte count. A reticulocyte count is how many new red blood cells that person is producing. So how is their body responding to the anemia? Somehow, some terrible rumor got started a long time ago that a reticulocyte count measured a vaso-occlusive crisis. And I don't know who started this rumor, but it's rampant and drives me crazy. A reticulocyte count is just how many red cells somebody is making. It does not tell you whether or not someone's in a crisis. We use it because if someone's more anemic than normal, let's say their hemoglobin is 5.5, we want to know, is their body trying to respond? Is that retic count high or is it low? If it's low, they're not making enough cells, and that might be because they are aplastic, or it could be because they had too much hydroxyurea or other medication. In a normocytic anemia, that means that the red blood cells are lower than they should be, but they don't look funny. They're not too small, they're not too big, and there are all these different reasons, and we don't need to worry about them. And then again, you can have an insufficient production, so your body's not able to make enough red cells. Our biggest concern for that are drugs, specifically hydroxyurea, or that they're aplastic, they have gotten a virus, and now their body's not producing enough cells. But look down here, one of the other main reasons your body might not make enough red cells is when your kidneys don't work and you don't have enough erythropoietin. Erythropoietin is produced by the kidneys, and when you start to have kidney failure, you don't make enough of it. And so we can see that, of course, in many of our patients, even with very, very mild kidney failure or mild kidney disease, not failure yet, they don't make enough EPO. And so we have to give them exogenous erythropoietin or Procrit. Now, you and I make a certain amount of EPO every day to ensure that our body keeps producing blood. But of course, our bodies don't destroy red cells very commonly or quickly. We destroy about 1 to 2% a day, but people with sickle cell disease might destroy as many as 20%. So 1/5 of their red cells could be destroyed every day. So they need a lot more erythropoietin than the average bear. And that's a real problem for our kidney colleagues to understand. So it's why we're often having to get extra approvals for Procrit. And then, of course, we always still worry about losing blood. So if we see somebody who's significantly more anemic than usual, we should still worry that something else is happening. They're losing blood in the gut, the urine, or somewhere else. We also worry about this in people who are oddly iron deficient. I can think of 1 or 2 where we worry they're bleeding somewhere in their gut and losing blood and not able to keep up with their iron supply. And then we talk a lot about hemolysis, or destroying red blood cells. So hemolysis, sickle cell disease, is a hemolytic anemia. The patients are constantly destroying their red blood cells. It doesn't come and go, but sometimes they might have more hemolysis than other times for lots of different reasons. And it's important because one of the things we talked about yesterday is when those red cells break apart, they release extra heme, and that heme is toxic to the inside of the blood vessel. And so if they have an event where they suddenly start destroying a lot of red blood cells at once, release a lot of free heme, it can cause massive sickling and vaso-occlusion. And that's what we see in our multi-organ failure syndromes. Also important, though, because there's another protein in the body that is there to soak up free heme. That's called haptoglobin. And in someone like you or me, you can measure hemolysis by whether or not there is haptoglobin, because all of us make haptoglobin, but when we measure it, we're only measuring unbound haptoglobin. Once that haptoglobin is bound to free heme, you can't detect it anymore. So often you'll see people checking a haptoglobin in people with sickle cell disease, but it doesn't mean anything because 95% of our patients have no free haptoglobin. It's all used up. So they check it to see if they're hemolyzing, but I try to explain to them, we know they're hemolyzing, they have a hemolytic anemia, so save the money, don't check a haptoglobin. And then, of course, we talked about how do you evaluate when we see somebody with anemia. The most important is looking at that reticulocyte count. Are they making blood or are they not? And then we love to know what that blood looks like because it helps us understand if the cells are normal or small or big or funny looking. The red blood cell count, right? That's another number you get. For the most part, you don't need to worry about it. It doesn't really help us. The 1 or 2 times we use it is this Menser index that can help you, and you don't have to do this, but it's a measure of volume based on red cell count, and it'll help you differentiate in someone whether they have thalassemia trait or iron deficiency. It does not work. This Menser count doesn't work in people with sickle cell. RDW, another measure, standard deviation of red blood cell width. This says how wide are our red cells. This is also useful. It really does help us differentiate between different sized cells or different problems. So that's something we use, but nothing you need to worry about. And of course, we talked about hemoglobin extensively yesterday. It's made up of these 2 alpha and beta units. It has an iron component in each chain. And when we talk about that pathology, as a reminder, it can be qualitative. So the hemoglobin the beta chain can be broken, like in sickle cell, or it can be quantitative where you don't have enough of those chains. And that's either alpha or beta thalassemia. And of course, again, that function of that red cell is to deliver oxygen. Finally, we come to platelets. I studied platelets for a long time. And they're really interesting in the blood because they're the first responder. I joke about if there's a party, then platelets are always going to know about it. They're going to the party. So whatever happens to you, whether you have a cut or an infection, the platelets think they need to come and help. And as a result, they'll often increase in situations of inflammation. Why is that important? Well, as you might imagine, since platelets are used for clotting, they're sticky. So in our patients, when they get an infection and their white count goes up and then your platelets go up too, well, then it's like more traffic for the red cells, right? So they're going to even have more problems and more ability to sickle and stick to the inside of the blood vessel. Like everything else, you can have too few or too many platelets, or you can have platelets that just don't work, or you can get really lucky and have platelets that don't work and there are not enough of them. Platelets are pretty cool. In their resting state, they look like these little flat discs, but they have all these cool things that can happen that we're not going to go into today. And when they activate, they look like an octopus where all these little pieces come out. Activated platelets, we still believe play a role in sickle cell and crisis, but we've never been able to sufficiently block it to make a difference. When we see thrombocytopenia, more than anything, if it is not something that a patient always has, which a few of our patients do, usually because they get stuck in the spleen, this should always worry you. If you see thrombocytopenia in someone with sickle cell disease, you should panic first and then make sure that everything is okay next. Again, we have some people who have chronically low platelets. Those individuals usually have a platelet count of about 80 to 120. And they tend to be people who are on high doses of hydroxyurea or people who have big spleens. And so the platelets get stuck in the spleens. But we really worry about this because it usually means that something bad is pending, usually that multi-organ failure syndrome that I talked about. These are all the other reasons you don't need to worry for now about thrombocytopenia. When you have too much or too many platelets, we worry specifically that you could have an increased risk of clotting. We commonly see this in very severe iron deficiency. So when I used to see what I called milk fat babies, those are 2-year-old babies who don't eat any food and drink all milk, so they don't have any iron, and they're really pale, really cranky, and really anemic. They have hemoglobins of like 2 to 4 and platelets of 1 million. That's the main time you see this, but the second time is after a splenectomy, because the spleen clears all the old platelets. And so if you take their spleens out, their platelet counts will go up. If they don't have a spleen, they may have higher than normal platelets. We usually don't worry. If they get above about 800,000, I put people on baby aspirin to help prevent clotting, but it's probably more to treat my anxiety than to treat the patient. We're not going to worry about that, and we're going to stop and see if anybody has questions. All the things you never knew you wanted to know about a CBC. All right, sounds good. Well, if you have any questions, let me know. Otherwise, we will, of course, share these slides. I'm going to put it up on my Dropbox account where I can share it with everybody most easily, and you can get to it from anywhere. So that will be coming to you soon. And other than that, have a lovely day.